VST, RVOT, and overriding RVH. And severity of the cyanosis determined by the obstruction to the pulmonary blood flow. That is the basic thing which decides. And late complications include arrhythmia, pulmonary regurgitation, and right heart failure. And the person who identified this condition is a French physician, Etienne Louis Fallot. And the components, these are the components. This is the picture to show that there are a lot of 4 or 5 variants of this components. And based on that variance only, the degree of cyanosis. Sometimes we may have no cyanosis at all, but all the defects may be there. And those patients are only called as a pink Tets or a pink Tetrology of Fallot. No or minimal right ventricular outflow tract obstruction and very little overriding of aorta. So it behaves more like a VSD rather than a right to left shunt. So more of a left to right shunt rather than right to left shunt, but still they are coming under the category of Tetrology of Fallot. And the extreme case is profound cyanosis even at birth because severe right ventricular outflow tract obstruction. So practically there is no blood flow into the pulmonary circulation at all. And this media in between these two extremes is the normal tetralogy that you see where they are becoming blue over a period of time and maintain that bluishness over a period of time. And if they have that infundibular spasm, they develop hyperspinotic cells now and then. So it is a acyanotic with near normal oxygen saturation, and there is minimal outflow obstruction. So it behaves like an unrestricted VST with a left to right shunt rather than right to left shunt. And in these patients, even if you don't correct the defect, they go in for heart failure because of the increased pulmonary congestion and blood flow. And the variants are usually another classification they ask you is about the duct dependent and duct independent. So this is a duct tetralogy of Fallots are all duct independent. They don't depend on any collateral flow from other systemic communications. Whereas people who have outflow tract obstruction, children or patients, they may depend on PDA for the circulation or from major collaterals from other aorta, which are present normally. In a palliative surgery, we are creating the same communication, but nature itself might have given these collaterals, and those patients also will not exhibit too much of a cyanosis because of this communication. And the common variant is absent pulmonary valve, and this is the pathophysiology that is happening. Right to left shunt through VSD is determined by the pressure gradient is another important thing, the amount of pulmonary blood flow that is going into the circulation. And the right ventricular outflow tract is obstruction is divided into fixed anatomical and variable. And this variable is the one which usually happens because of the infundibular spasm. Otherwise, if there is a pulmonary atresia or a pulmonary stenosis, that is a fixed one that will not change over a period, whereas this variable only causes the hyperspinotic spells. So the subvalvular muscle bundles causing the swelling or the hyperspinotic spells which can happen. And the systemic vascular resistance is a very important thing to reduce the quantum of blood flow from the right heart to the left heart. So if you are able to maintain or increase SVR, it will prevent the blood flow from the right side. And this is the basis of treatment of swelling episode, because you either squat to increase the SVR or you give phenylephrine to increase the SVR. And this flow diagram tells you how it is getting worsened. Reduced SVR, infundibular spasm, increasing the pulmonary vascular resistance. This goes on in the manner to cause more and more deoxygenation. So another factor is PVR. So you must always balance the pulmonary vascular resistance with the systemic vascular resistance. You should try to decrease PVR, increase SVR. If you do that, you will be able to achieve a normal oxygenation because of the prevention of communication or right-left quantum. And the diastolic function and heart rate, right ventricular diastolic impairment happens, and over a period of time there is a reduced filling that also adds to the problem. And associated conditions which are of importance, paradoxical embolism. That is another point the examiners are very particular. So all the IV sets that you use, you must check that there is no air bubble in the line, and thrombophilia due to polycythemia, and 25% have abnormal congenital anomalies which are related to the they may be tracheoesophageal fistula and trisomy 21 also, and they need SBE prophylaxis. And the typical signs of TOF, central cyanosis, which is not improved by breathing 100% oxygen. Please remember that in the exam. The second thing is clubbing, seen from the 3rd to 6 months. It will not be present at birth, and you will have a long, harsh ejection systolic murmur, best to be heard over pulmonary area and the left sternal border. Sometimes you may feel a thrill also along the left sternal border. And complications of long-standing cyanosis are stroke and intracerebral abscess, neurodevelopmental delay, arrhythmias. The associated anomalies, the Dye-George syndrome is the most common anomaly that may be there, and these children will require irradiated blood transfusion. This syndrome is mainly produces a immunocompromised state because they don't have the T cells to produce their normal immunity, and so they may require treatment accordingly. And they may have isolated cleft lip and palate. Hypospadias is another condition which may require surgery in these children. So that is another associated anomaly which you have to keep in mind. And there may be skeletal anomalies also, like money disease or syndactyly. All these things are also possible. Things can cause this problem. And repaired Fallot tetralogy, the repair what is normally done is the closure of the ventricular septal defect. That is the first thing, and separating the pulmonary circulation from systemic circulation. Then you have to remove the obstruction to the right ventricular outflow. So that can be done by enlarging the thing. So depending upon the nature of the origin of the pulmonary artery, whether it is a pulmonary valve stenosis or the infundibular section of muscle fibers or a transannular patch which is causing the constriction, or beyond the valve there may be a narrowing of the vessel which may require a patch graft. So chronic problems after repair may be chronic pulmonary regurgitation, or there may be recurrence of pulmonary stenosis, RV enlargement and dysfunction, aortic root or valve dilatation, arrhythmias are all the problem. The TET spell is usually because of the infundibular spasm, which increases the right side pressure. So more right side pressure leading to increase in right to left hand. Management: 100% oxygen, fluid bolus, sedation with morphine, knee chest position, phenylephrine, and propranolol 0.1 to 0.3 milligram to reduce the infundibular spasm. And anesthetic goals in these patients are, of course, we have discussed all these things. Keep the PVR low, keep the SVR normal or a little above than normal. That is the basic thing that you have to remember. And this is the modified Blalock-Dosek shunt for which you have to give balanced anesthesia. The preparations are, you must always have 1 unit of blood ready because it's a surgery involving the major vasculature. So anytime you may need a blood. And balanced anesthesia with intubation, intraoperative analgesia with say fentanyl up to 5 micrograms, and invasive monitoring with central arterial line. And surgeon may clamp the subclavian artery, especially if it is a left subclavian artery. Don't put your arterial line on that side. That is very important practical point that you have to remember. Usually they go for femoral arterial access so that even if they choose suddenly the right side, you will not be caught unaware. So better to go for femoral arterial line. And it's a non-bypass cases. Small dose of heparin will be given before the side clamps are put. And inotropic support with adrenaline may be required after the shunt has been opened. And infundibulous spasm is not a concern in this situation because you are going to bypass that and blood flow will happen. And inspired oxygen you have to reduce at the end of the procedure to 30% to see what is the response. In the ideal situation, it should be 80 to 85. And if the shunt is too small, the saturation will drop to 70. And if the shunt is too large, it will go up to 100 with even 30% oxygen. So that's it, the way you identify the size and the perfusion that is taking place in the pulmonary circulation. And post-surgery, after the shunt has healed and other things, these children may come for some incidental procedure, may represent further cardiac or non-cardiac surgery. And here it is a question like putting a stent in a cardiac patient, coronary artery disease patient. Our aim is to prevent any blockage in the shunt. So you must, the pulmonary flow is dependent on the patent shunt, and check shunt patency preoperatively. SpO2 should be more than 80, and there should be, you can hear the shunt murmur here because there's a communication between the subclavian and pulmonary. You can hear the shunt murmur. You may assess the patency by echo and avoid dehydration. Consider intravenous fluid preoperatively during the starvation period itself, and maintain blood pressure during surgery. Consider a fluid bolus if saturation falls. And you must monitor these children postoperatively. So the most important thing is adequate hydration and maintenance of pressures. And postoperative restrictive physiology. This is another complication that can happen following repair of PO. The right ventricle may exhibit signs of what is called restrictive physiology. This is due to systolic and diastolic myocardial infarction, which of course you can detect in the pre-op phase by proper echo studies itself, and associated with difficulty in achieving myocardial protection of the hypertrophied right ventricle. So the right ventricle becomes stiff and unable to relax and accept the atrial volume during atrial systole. This is seen in the Doppler echo as antegrade pulmonary flow in diastole. So even during the diastole of the right ventricle, there will be some flow into the pulmonary artery, and restrictive physiology associated with low cardiac output, and they may go in for renal failure and pleural effusions. And it is difficult to predict which patient will develop the restrictive physiology, but more common in children who have severe right ventricular outflow tract obstruction, where it is corrected with what is called the transannular patch at the level of the valve. And the patient should be managed with adequate filling, and they may require milrinone as a inotropic, improve the circulation, and other inotropes also. Diuretics and later peritoneal dialysis for any renal impairment will be required. Another important complication is the junctional ectopic tachycardia. It is seen after cardiac operation, but most commonly after surgery to close to the bundle of fish, as in TOF, because the VSD is very large, and when you take a bite with a patch graft, you may go through this bundle of fish and cause a problem. It may be difficult to treat because it will exacerbate the effect on the right ventricular dysfunction, and it should be treated aggressively. This is one of the very serious complications. The patient can be cooled to 34 degrees, muscle relaxation to reduce workout breathing. You can give magnesium sulfate 25 to 50 milligram per kg loading dose, repeated as necessary. Amidrone infusion is required because it's a tachycardia condition. So all these drugs are involved. And postoperative rectal physiology with or without junctional ectopic tachycardia usually resolves within 2 to 3 days. But ventricular dysfunction may recur and be a long-term problem. Restrictive physiology is associated with increased duration of postoperative ventilation, intensive care therapy, and in hospital mortality also. So drainage of a brain abscess in uncorrected TO wave, there are many factors responsible for this. Bypassing the pulmonary circulation and blood in the patient is not filtered, and normal alveolar phagocytosis is not happening, and direct entrance of pathologic microorganisms into the circulation, and brain being hypoperfused with severe hypoxemia and acidosis resulting from secondary polycythemia. The pathogens get settled well there and get to form the brain abscess. And the patient will have fever, coagulopathy, dehydration, electrolyte imbalance, and metabolic acidosis, which all need to be corrected prior to surgery. And the preparation before anesthesia are keeping the inotropes and vasopressors ready, and prophylactic antibiotics should be given, and de-airing of all intravenous lines should be done. You can give fentanyl 2 to 4 micrograms, midazolam, atracurium, and sevoflurane isoflurane inhalation, and ventilation can be controlled. Besides routine monitoring, you may have to use intra-arterial monitoring and CVP and the arterial blood gases. Isotonic fluid therapy should be given. You have to keep fresh frozen plasma and platelets ready. And scalp block may be given to block the supratrochlear, supraorbital, zygomatical temporal, auriculotemporal, greater and lesser occipital nerve. So that has also been approved as a one of the techniques for this. So these are all some of the points I thought will be useful for exam purposes. And the problem here is many of us, including the senior people, would not have had a chance to witness these cases unless you are a cardiac anesthesiologist and exclusively working in that. So you must be aware of all the common problems that you have to at least know the theoretical aspect of it. And that is the reason why I took a little longer time for discussing this particular subject. Any questions, any doubts?